Today at CMSC, Doctors Valerie and Bove were part of a presentation on integrating wearable technology into MS clinical care. Dr. Block is a physical therapist and assistant professor of physical therapy at the UCSF Weill Institute for Neurosciences, and Dr. Bove is a practicing neurologist and clinician scientist at the UCSF Weill Institute for Neurosciences. You know, despite the massive amounts of money and development in digital tools, very few have actually crossed the divide into routine clinical care. So I'll ask each of you, what's the primary roadblock preventing a validated digital biomarker or wearable tool from becoming a standard part of an outpatient neurology visit? Is it an interface problem, a billing issue, workflow challenge, or something else? Dr. Block?
Well, I think for one, it's all of the above. And for two, it's that MS is so heterogeneous. So you have to find a tool that can pick up the differences for all the different people with MS and their symptoms and problems, and maybe what's going to predict their disability.
Dr. Bove, same question.
Also, all of the above. I think we know that different people with MS want to use different tools for different reasons. And so there's a gap where we need something that can ingest all the different tools and give us the same information. On the clinician side, we need that information to get all the way through to the clinician's medical record, which is where they make decisions. And that is a workflow issue, and it is a billing issue, because that has to take up some part of the clinical visit.
Dr. Bove, you've worked on the Bridge Precision Medicine dashboard to bring data directly to the point of care. Can this kind of tool effectively display months of continuous step or sleep data to a neurologist in a way that's interpretable in what tends to be a relatively brief clinical visit?
That's absolutely our goal. We're in sort of the trial phase of this, because you have to show it. But from sort of what we've seen so far, clinicians really appreciate being able to see trends over time, being able to see when a patient's function dips and discussing with the patient why that was so, and also measuring whether the interventions that they recommend happened and reached the target goal.
Dr. Block, as a physical therapist and researchers, how does the clinical utility of this data differ between the neurology evaluation and a physical therapy or rehabilitation setting?
Well, I think what we're trying to do is change behavior more. And so using this information maybe as biofeedback, or to have a goal, like an attainable goal for them to do, and then you have tools and treatment methods to reach those. I think that having something that's actionable, like what Dr. Bove's built with Bridge, and being able to pull that into the clinic, not only so I can see and I can act on that data, but also so that the patient can see the data. And then that can help motivate them and help give them the feedback that they're actually doing better. Because a lot of times I tell them you're doing better from when you first came in, and they don't believe it because they don't see it, because they've been incrementally changing and they haven't had that feedback.
You're leading work on the Wearables for the Bladder study using external ultrasound devices. Bladder dysfunction impacts the majority of people with MS, but notoriously difficult to accurately track between appointments. What have you learned through this study about how real-time bladder monitoring changes patient self-management and pelvic floor physical therapy?
So one of the things that I think both the clinician, the sort of neurologist, and myself, and the rest of our team hadn't really realized, maybe we knew in the background, was the variability and the fluctuation of symptoms, for bladder symptoms. And so what we measure in clinic can be completely different from how they are during the rest of their day. So they're telling us that they're not voiding fully, and yet we'll do residual or PVR, and they fully void their bladder in the clinic. But I believe the patient, it's just that we don't have an objective measure, whereas with this, we can see that change throughout. There's the potential for using it instead of having an indwelling catheter, maybe to know when to use catheter to maybe avoid urinary tract infections or other things like that. And then one of the things that we've sort of started to see is patients who, not just with voiding or post-root residual intention, but also people who were trying to get to have less urgency and frequency, and seeing how much urine is in their bladder and be able to sort of hold it just that little bit more. Okay, one will bring up, and then you can reach the next, and then seeing how that increases can really help motivate treatment and the patients.
As Dr. Block was explaining the variations between what's measured in the clinic, and what happens in real life, it occurs to me, it's not just bladder function. I'm thinking about the patient that you might see at 9 a.m. and their 25-foot walk, and that same patient, same 25-foot walk at 4 p.m. Or someone who is dealing with fatigue at home and doesn't happen to be fatigued the day they're in clinic. It seems that wearables, digital technology, are really going to be able to start showing what it really is that patient deals with day in, day out.
Yeah, absolutely. In the stroke world, we talk about the penumbra. So you have the stroke and you've had some tissue that has sort of lost oxygen and, may be beyond repair. And then you have some tissue that may be at risk of losing oxygen, but that is still functional. And that's sort of the penumbra around the shadow around the stroke territory. And I think in multiple sclerosis, just as you say, the ability to see that the walk-in is fatigable, the bladder is variable, they do more early morning than they do late afternoon. All that information tells us what domains, what function is actually at risk, what's the penumbra of their function, what is at risk in post. And I think that's a really valuable biological signal we don't have, as you say, when we see a patient at one time.
Well, I guess to that point, in addition to wearable sensors, your lab has looked at consumer-driven digital input like selfie video from patients to measure their physical function. How do you see passive wearable data and active digital patient-reported outcomes working together to create a composite picture of that patient's true status?
I think, as you say, they have to work together. For, passive means the patient isn't doing something and they're not responding to a prompt. They're not responding to an action. They're just living their daily lives, and the wearable is measuring that. And that gives us a beautiful portrait, sort of longitudinal. But the sort of active prompts that we're using when we ask the patients to self-record their selfies actually gives us a really nice sort of more spot, one moment in time or over several days, several moments of time where we really see how they're really functioning in their daily world, doing things that matter to them, buttoning their fur, feeding themselves, walking in their room. And so I think those do provide really complementary information. If you want to follow people over the really long term and get a lot of information, passive is going to be much better. And because you can't ask people to do burdensome things all the time. But a low burden task that you ask them to do every 2 months, for instance, is totally feasible.
Today's presentation was largely about taking a lot of the data collection we're talking about and putting it in the phone. Now, a major promise of wearables, as Dr. Block just pointed out, is their ability to detect changes that a patient might not even notice or mention during their visit. When a wearable dashboard flags a sudden drop in the average daily step count or a significant disruption in their sleep pattern, what's the protocol for the clinical team? How do you prevent that data from creating what I'll call alarm fatigue for both the clinician and the patient?
Yeah, that's a great question, and that is really a workflow question. And the ideal situation would be that the clinician and the patient together decide on the alarms. So if someone is sort of feeling low grade, a little sad all the time, they don't want their doctor alerted every day, right? They want to decide what would constitute something that for them is substantially different. And I think being able to select the alarm thresholds and triggers is actually really key to reducing alarm to long term. And then being able to troubleshoot. Hey, you're doing this, and we sort of, you've gotten better. Now let's change the alarm, right? To more restrictive or more permissive, right? Let's kind of evolve as the function of data. I think it's going to be a key component because you're right. We can't have alarms.
Dr. Block, patients can feel excited and motivated when they see their own data, but over time that engagement can taper off. What have you found to be the most effective way to keep patients actively involved with their wearable devices once novelty starts to wear off?
That's a great question. And I think there's not an easy answer to that, but with studies and in clinical care, I think it is a person-to-person interaction. I think they need to feel kind of some ownership of it. And as Dr. Bove talked about, like designing a tool that they find interesting, that they get something back from, that they can see these changes. And then I think interaction with the provider, that they're seeing, that they're hearing, that they're understanding some of the things that maybe have been difficult to show or elicit in the clinic, that they're able to see that and track that, and that they are responding to that in a way that can hopefully see changes.
Dr. Bove, the consumer digital devices are created for the mass market for most people. MS presents with a variety of symptoms, including cognitive fatigue, manual dexterity challenges, and visual impairments. So how do we apply human-centered design to ensure these tools remain accessible to patients who might have the highest degree of disability and most to gain from this kind of remote monitoring?
You can imagine that someone who has disability across several domains would end up wearing like 16 different devices, right? That need to be paid for, charged, calibrated, interpreted. And that would be overload for that person. That's not serving the needs of that person. So I think, again, the combination of, what is low touch, low burden, gives you a good snapshot, and then what you want to monitor. And it can be for the time being, right? So maybe for the time being, they want to focus on one device, on, getting a person to move around a bit more. And once we sort of achieve that goal, maybe we pull in or switch out a new device, right? So it doesn't have to be all at the same time forever. I think you can really be a little bit more selective based on what your prioritize, because we see for people difficulty in multiple domain. If you send them out with your long list of all the things they have to do to tackle all their symptoms, it's going to be overwhelming, right? And so part of the care plan and part of the shared decision making is figuring out what do we do first and then what do we do next. So I think similarly the devices involved with that decision making.
Well, Dr. Riley Bove, Dr. Valerie Block, it's not often that I find myself surrounded by so much expertise, but I want to thank you both for all you do to improve the lives of people living with MS, and thanks so much for talking with me today.
Thank you, John.
Thank you, John.